Bismillahirrahmanirrahim. Today we will discuss some MCQ on the psoriatic arthritis. A 32-year-old female with pain and swelling in the joint of right hand. Examination show tenderness in the MCP, PIP and distal interphalangeal joint. There is also dystrophic hyperkeratosis of the fingernail. What is the most likely diagnosis? So this female patient has asymmetrical arthritis and it has also involved the distal interphalangeal joint with nail changes, and we know one condition that causes the oligoarticular asymmetrical arthritis with distal interphalangeal joint involvement and dystrophic hyperkeratosis in the nail, and that condition is the psoriatic arthritis. So here the correct answer is option D. Which is the correct answer? This is option D. Rheumatoid arthritis does not involve the distal interphalangeal joint, and it also does not cause the oligoarticular asymmetrical arthritis, but it causes the symmetrical arthritis. So option D is the correct answer. Question number 2. Pencil in cup deformity is shown in which of the following condition on X-ray? Rheumatoid arthritis. This is incorrect. Osteoarthritis. This is incorrect. Psoriatic arthritis. Yes, pencil in cup deformity is shown in the psoriatic arthritis. So option 3 is the correct answer. Hemochromatosis and chronic gout does not cause the pencil in cup deformities. Question number 3. Which of the following should be avoided in psoriatic arthritis? Methotrexate. No, this is a good choice for the psoriatic arthritis. Leplonamide. It is also a good DMARD. Ustekinumab. It can also be used in psoriatic arthritis. Apremilast. It is also used in psoriatic arthritis. Hydroxychloroquine. Yes, hydroxychloroquine should be avoided in psoriatic arthritis because this is an antimalarial and it will exacerbate psoriasis. So the drug which should be avoided in psoriatic arthritis and can be remembered by the mnemonic plebs. P means painkiller, like NSAIDs. L means lithium. A means antimalarial, like hydroxychloroquine. AC inhibitor. B means beta blocker. S means steroid. So this is the mnemonic for the drug which should be avoided in psoriatic arthritis. Question number 4. A 26-year-old female present with pain and stiffness in her hand. She has a history of psoriasis. Examination show ectosynovitis in small joint with severe plaque psoriasis. What medication you will start? So this patient has psoriatic arthritis and she also has psoriasis skin rashes. So drug which will help both the skin condition and will help the arthritis component. Which drug will be most suitable for this patient? Infliximab. Yes, it can be used, but this is not the first line treatment. Oral prednisolone. This should be avoided because it will exacerbate or it will cause the pustular psoriasis. Hydroxychloroquine will also exacerbate the skin changes. Sulfasalazine. Sulfasalazine will help the arthritis component, but it will not improve the skin component. Methotrexate. Yes, it will help both the skin condition and will also improve the arthritis component. So option E is the correct answer. Question number 5. A 43-year-old builder, known case of psoriatic arthritis and psoriasis, has developed a deforming distal interphalangeal joint polyarthropathy. Over the course of past year, he is now unable to continue his job due to pain in his hand. Currently, therapy includes methotrexate as a required naproxen for the pain relief. He has already failed to a trial of sulfasalazine to control his symptom. On examination, there is extensive synovitis, psoriasis on the scalp, elbow, knee. Which of the following is the next step? So this patient has psoriasis and psoriatic arthritis, and this patient is unable to continue his job due to pain in his hand. This patient is currently taking methotrexate and naproxen when there is pain, but this patient has also failed to respond to sulfasalazine. So this patient has tried two DMARDs and a NSAIDs. So the next line treatment is anti-TNF, golimumab. This is the correct answer. Option A is the correct answer. Let's see the other option. Option B, low dose prednisolone. This should be avoided because it will exacerbate the skin changes. Tocilizumab. It is not a good option here. Ustekinumab. Yes, it can be used, but the second line treatment is the anti-TNF, which is the golimumab. Hydroxychloroquine should also be avoided because it will exacerbate the skin changes. So let's explain this thing. When there is psoriasis with psoriatic arthritis and the patient uses two different DMARD like methotrexate and sulfasalazine and the symptoms do not improve, then the next line of treatment is the anti-TNF. And we know that anti-TNF can be remembered by the mnemonic AIECG, adalimumab, infliximab, etanercept, certolizumab, and golimumab. Assess response at 12 week. When you start anti-TNF, then assess response at 12 week by doing the inflammatory marker, that is CRP and ESR, and scoring system, that is DAPSA, disease activity in psoriatic arthritis. If the score is high and the inflammatory marker is raised, it means that the patient is not responding. Change it to another anti-TNF alternative drugs. This is the correct answer. Here is golimumab. The patient has tried two different DMARD and the patient symptoms and arthritis component is not improving. So go to the next line treatment, that is the anti-TNF. The correct answer here will be golimumab. Question number 6. A 52-year-old female male present with pain and stiffness of small joint of the hand that is worse in the morning and can last several hours. He also complained of occasional digit swelling. What is your diagnosis? So this patient has pain and stiffness in the small joint of his hand, but this patient also has a history of dactylitis, that is swelling of the entire digit dactylitis, which occur in the psoriasis. So what is your diagnosis? Diagnosis is psoriatic arthritis. Correct answer here is psoriatic arthritis. This patient has arthritis and dactylitis. Question number 7. There are how many patterns of psoriatic arthritis? And we know that there are 5 patterns of psoriatic arthritis. The most common, the most deforming psoriatic arthritis, arthritis multilan. Yes, the most deforming pattern is the arthritis multilan, which is the telescoping of the finger. This is the most severe and deforming arthritis. The most common pattern of psoriatic arthritis is the oligoarticular asymmetrical. So the option E is the correct answer. And we know that there are five patterns, and this can be remembered by the mnemonic drama: distal interphalangeal joint involvement, rheumatoid-like, asymmetrical oligoarticular, which is the most common one, multilance, which is the most deforming one, and ankylosing-like. So the most common pattern is oligoarticular asymmetrical. Question number 10. The most common nail finding in psoriasis or psoriatic arthritis. The most common nail changes in psoriatic arthritis is the pitting of the nail. The most Question number 11. The most specific sign in psoriasis is the oil drop sign. So the most common nail changes is the pitting of the nail, while the most specific sign for this in the psoriatic arthritis is the oil drop sign. Question number 12. Which of the following statement is true regarding psoriatic arthritis? Skin disease always precedes joints. So this is not the correct answer, because arthritis may precede the skin changes. One third of the patient with psoriasis develop psoriatic arthritis. And we know that 10 to 20% of the patient with psoriasis develop psoriatic arthritis. So this is also not the correct answer. Management is physiotherapy and analgesia. And we know that psoriatic arthritis should be treated in the same way as we treat the rheumatoid arthritis. Arthritis multinan is the most common subtype, and we know that oligoarticular asymmetrical is the most common subtype. Male and female are equally affected. Yes, this is the correct answer. Option E is the correct answer. In psoriatic arthritis, male and female are equally affected. Question number 13. Approximately what percentage of patients with psoriasis develop an associated arthropathy? So option E is the correct answer. 10 to 20% of the patients with psoriasis develop psoriatic arthritis. Question number 14. Why systemic steroid should be avoided in psoriasis? Systemic steroid should be avoided in psoriasis because if you want to taper the steroid or withdraw the steroid, it will cause the pustular psoriasis. So it should be avoided in psoriasis. Question number 15. A 36-year-old female suffering from manic depression was referred to the psychiatrist. She was started on the medication that caused exacerbation of her psoriasis skin lesion. Which of the following medication is the culprit? Means this patient is manic and she is also suffering from the psoriasis, and the psychiatrist started her on some medication which exacerbated his psoriasis skin lesion. So which medication is the culprit? Amitriptyline. This is not the culprit. Paroxetine. This is also not the correct answer. Risperidone and haloperidol also does not exacerbate the skin lesion in the psoriasis. Lithium. Yes, this is the correct answer. Lithium can exacerbate the psoriatic skin lesion. So there are drugs, infection, alcohol and trauma which will exacerbate the skin lesion in psoriasis. Drug can be remembered by the mnemonic PLAB. P means painkiller like NSAIDs. L means lithium. A means ACE inhibitor, antimalarial. B means beta blocker. So these are the drugs which exacerbate the skin lesion in psoriasis. Infection like viral infection and bacterial infection both can exacerbate the skin lesion. Viral infection like HIV, bacteria, streptococcal infection exacerbate the gutted psoriasis. Alcohol can also exacerbate the skin lesion, and trauma can also cause the exacerbation of the skin lesion. So these are the condition and drugs which exacerbate the skin lesion in psoriasis and should be avoided. Thanks.